Good morning, it's Dr. Soloway from the Soloway Says Show featuring Bob Barker and all the other Price is Right people. Okay, no, back to reality. So, excuse the mark on my cheek. I think I used a sandblaster to try to get out an ingrown hair, and I look pitiful. I apologize for all you people that watch only because I'm attractive. No, I'm kidding about that too. So this is supposed to be about hip pain, so let's talk about the hip. First of all, here, we're going to look. That area under my lard ass of fat, that area in the crease by my pocket right here, that's the hip joint, okay? Now, right here, where you guys call the hip, that's called your trochanter. Right here, where the British call it the bum, just under the pocket, that's your buttocks. Okay, so now that we have an anatomy lesson, number one, first of all, where do you feel hip pain? You feel it in the groin and running down the anterior portion or the inside part of your thigh. What makes it worse? Crossing your leg. How do you walk if it bothers you? You have what is called the Trendelenburg gait. That's spelled T-R-E-N-D, Trendelenburg gait. That's when you swing the hip. That's in a really bad hip. If you see somebody walking like that, they should have their hip replaced. And for the record, a girdle stone is when the hip is removed and you're left with no hip whatsoever. Those people have a really severe Trendelenburg gait. Okay, so what causes hip pain? Osteoarthritis, fractures, microfractures, avascular necrosis, fluid in the hip. What causes fluid in the hip? Any arthritic process that I treat. Rheumatoid arthritis, scleroderma, Sjogren's, myositis, psoriasis, ankylosing spondylitis, sarcoidosis, IgG4 related disease, osteoarthritis. I'm sure there's more, but that's what I thought of for now. So, if you have pain in the groin, what do we want to do for you? We want to drain the fluid. We want to analyze it. We want to make sure there's no gout. We want to make sure there's no pseudogout or calcium crystals. We want to make sure there's no fracture. We would see lipid in the fluid. When I say we, I'm talking about a rheumatologist who's trained to look at fluid. This is not something you can get at a local orthopedic office, and this is not something you can get at a local lab. This is something specific for rheumatology. Okay, next. We drain the hip. We make a diagnosis. As long as there's no infection, we inject anti-inflammatory medicine into the hip. Do we cure the hip? Sometimes we do, sometimes we don't. Those are topics for different lectures. Next, hip joint pain, femoral acetabular impingement syndrome, and hip labral tear. These are issues that are often treated with physical therapy and occasionally do need orthopedic surgery. There are some very good orthopedic surgeons that I work with that are excellent at repairing the femoral acetabular impingement. There are some very good orthopedic surgeons I deal with that will replace or decompress an avascular necrosis of a hip, which is essentially a dead bone within the hip. And labral tear, if it can't be fixed with physical therapy, sometimes the labrum is difficult and has to be repaired surgically. This is a very grueling surgery. I don't recommend it if you can avoid it. The hip has to be dislocated by a machine and then be worked on and then put back in. Surgeons have a slogan, and I like this slogan. And it goes like this. Go where you gotta go, do what you gotta do, and get out. Okay? So that's the mindset of a smart surgeon. You go where you gotta go, you do what you gotta do, and you get out. You want to keep the person open as short as possible. You want to not expose them to infections. Okay, so that's the actual hip joint. Now what about the other 98% of the people that come in complaining of hip pain? Okay, if you've got pain on the outside of your thigh, up near the hip area, and it hurts when you lie on that side when you sleep, if I'm referring to you and you can't sleep on your right or left side because you have what you think is hip pain, 99% you've got bursitis of your trochanter, which is hip bursitis. You need to come over here and get a depomedrol injection into that bursa because the bursa doesn't have a good blood supply. But with my strategic accuracy, you're going to get better 99% of the time. Next, what happens if your butt hurts? Because again, all you people with butt pain say my hip hurts. Okay, now, you may be right because the front of the hip is in the groin, but the back of the hip is in the butt. But most people with butt pain only butt pain are not going to have posterior hip pain. They're just not going to have a hip process, so they have something else. The most likely couple of possibilities include bursitis of the gluteal muscles, or under and around the gluteal muscles, tendinitis, arthritis from the lower lumbar spine that is manifesting in a way that it is mimicking the buttock pain, which you call hip pain. The other thing that you can have, which is not uncommon, and we see it, we see a lot of iliotibial band syndrome. We see a lot of piriformis syndrome. And to close out this lecture, or speech, or discussion, or whatever you'd like to call it, you can call it a cartoon, really. A lot of people go to pain management and they get sacroiliac injections. In my expertise, and I've been in this almost 30 years, quite frankly. I graduated medical school at 25 years old, and I'm past 55, so that means that I'm out of this for quite a while. The sacroiliac joints in general are another topic, but you need to know about this topic. Why do you need to know about it? Well, for one, it's extremely common. In fact, the spondyloarthropathies as a group, which include ankylosing spondylitis, psoriatic arthritis, the arthritis of Crohn's and ulcerative colitis, and on occasion sarcoidosis, and on occasion reactive arthritis, or what was known as Reiter's syndrome. There are many more, probably double the amount of those patients than there are with rheumatoid arthritis. Generally speaking, rheumatoid arthritis does not involve the sacroiliac joint. Generally speaking, the other conditions probably involve the sacroiliac joint at least 50% of the time. Based on that information, if you've got pain in the buttock, one side or both, you need to be evaluated for sacroiliitis, and you need to be diagnosed with a problem. And once the problem is known, it can be treated. To rush off to somebody who'll stick a needle in your sacroiliac joint is putting a Band-Aid on a broken inner tube. It'll last for seconds, maybe a minute, and that's the end of it. So, yes, I occasionally do sacroiliac injections, but this is for an established patient who already has, let's say, Crohn's disease or psoriasis or psoriatic arthritis with known sacroiliitis that is not already controlled by using one of the TNF inhibitors such as Remicade or Enbrel or Humira or Simponi Aria or Cimzia or whichever other one I forgot. There was no bias to any company there. Those are the ones I could think of. Some I like, some I don't like. There's various reasons. I hope this was a good summary for the average person who's a non-physician or a physician. I hope this makes sense. I hope I didn't talk too fast. I hope you didn't mind staring at that crazy-looking zit on my face that I tore apart. And I hope you have a wonderful day. So, again, you keep the questions coming, and I'll keep the lectures going. Take care.